So we'll see the sections of the MRI. So in the sections, we have multiple sections, like we have sagittal section. Why we call it sagittal section? Because it divides the spine into two halves like this. Sagittal suture is there, sagittal section. So we are dividing the spine into two halves like this. So that is sagittal section. The axial section, this is through the transverse plane, like this. We are taking the sections like this. Okay, so that's a axial section. And this is a coronal section. Coronal section means from the coronal suture is there, coronal suture, right? The coronal suture is there. So we divide the, basically takes the sections from the anterior to posterior or posterior to anterior. Okay. So if you look on the left side, you can see, if you can appreciate this blue line over here. Can you see this blue line here?
Yeah.
Okay. So this section is taken like this. Okay. From the posterior part. So that's why. So this is what? What section is this?
That's coronal.
It's a coronal section. Coronal sections. Now we are going from posterior to anterior, right? We are taking it from here and we are going anteriorly. So in the posterior part, we are taking it from the posterior part, from the posterior back. So that's why we can see all the paraspinal muscles over there, right? As we start going anteriorly, this will move anteriorly. As you start going anterior, we can see the muscles over here, the fascia between the muscles. We can start seeing the individual muscles over here. Okay. And now we have started seeing in the lower part, we start seeing the spinous process. Now you can see the spinous process over here, in the center over here. Okay. So we are going from posterior to anterior, and we can start seeing all the structures over here. Now, if you look at this area, the lower spine, lumbar spine, in the lumbar spine, we are at the somewhere at the laminar level. You can see the facet joints over here. What is happening here? Here you can see the spinal cord. You can see the nerves.
Yeah.
Why? Because of the lordosis.
Yeah.
Because of the lordosis, we are still in this part, but here there's a kyphosis. So that's why we have reached the spinal canal level in this part. So that's why we can see over here the spinal cord, and we can see the individual nerves over here. Okay. As you go more anteriorly, we start going more anteriorly, we can see all these nerve roots over here inside the spinal canal. And these nerve roots are going towards the respective foramen. They are coming out of this thecal sac. You can see there's a pedicle over here. And you can see the nerve roots are coming out of their respective foramen. So similarly, we can see all these nerve roots are going towards their respective foramen. Okay. This is the S1 root over here. It's going towards the S1 foramen. Okay. And now we are reached to the vertebral body level. Now we can see the vertebral bodies over here. Right. This is all from the vertebral bodies. And along with that, we can see the psoas muscle over here. Quadratus lumborum and the psoas muscle. Okay. So now we are in the psoas compartment over here. Okay. All right. So why this section is important? Why these coronal sections are important? The coronal sections are important to see because when we want to trace something from anterior to posterior, from posterior to anterior, when we want to trace something which is lying vertically, like this. If something is lying vertically like this, and if you want to study this entire area, we have to take sections from the coronal sections. So which one is important for us? Like sacroiliac joint, SI joint. Okay, sacroiliac joint is like this, right? On both the sides, they are vertically oblique inwards. They are like this on both the sides. If you want to study the entire SI joint, you have to take a sections from the anterior to posterior or posterior to anterior. Now look at this. So we're in the posterior part of the joint here. As we go more anteriorly, we can start seeing the posterior joint, entire posterior joint over here, dorsal joint. Now we have reached the middle part of the SI joint. And now we are going towards the anterior part of the, now this is the anterior part of the SI joint. Okay. So when you are suspecting any pathology in the SI joint, if you are suspecting sacroiliitis, don't order MRI LS spine. If you order the MRI LS spine, they will take the axial sections from this part of the LS spine. They will take the sagittal sections from the LS spine, but they won't take any coronal sections. So when you're suspecting any pathology in the SI joint, you have to order the MRI SI joint. Because when you order MRI SI joint, then only they'll take the sections, coronal sections from the SI joint. And then only will you be able to see the entire joint. Okay. So pathology may be in the posterior joint, maybe in the anterior joint. Okay. So that's why it is important to see the entire SI joint from posterior to anterior. Okay. Also, at times, coronal sections are required when you want to trace suppose there is a correction over here, paraspinal correction is there, and we want to trace this correction from where it is coming. In that case, again, we have to go from posterior to anterior to see that where is the correction coming. Suppose there's a correction in the source compartment, whether it is coming from this joint or this, from where it is coming. It is coming from outside the spine or it is coming from within the spine. Or at times we have some cyst. Now, if you want to see the cyst, whether it is coming, it's an arachnoid cyst, whether it is an arachnoid cyst or it is a facetal cyst. Okay, again, we have to go for the coronal section and we can see that, suppose there's a cyst over here, somewhere here, and we want to see whether it is coming from the arachnoid, is a arachnoid cyst or a facetal cyst. We have to take a coronal section. We can trace the
21 hours.
And suppose there's a cyst over here, we can make out that whether it is coming from the arachnoid, from the dura over here, or coming from the facet joints. So this is how we can differentiate. This is why coronal sections are important. And nowadays, when we do endoscopic discectomies, in that case, it is again very important for us when we do endoscopic. Suppose there's especially for the L5S1, L4, L5 region, when there's extrusion of the disc or sequestration of disc, we want to see when we go interlaminar, when we go from the posterior side, interlaminar approach. That time we want to see what is the safest route to enter. Because before we enter inside the canal, before we put our scope, till the time everything is done under fluoroscopy guidance. So if you have the MRI understanding, that suppose there's a compression, there's a herniation over here. Now I want to enter over here, and I want to see that when I enter from the posterior side, where's this nerve root lying? Whether it is pushed medially or it is pushed upwards. Where's the fragment lying? So that I can approach my scope according to the fragment. Suppose it is this fragment is here and it is pushing the nerve here in the center. I will go towards the facet joint. I'll enter from the facet joint. Suppose this nerve herniation is over here and it is pushing the nerve upward over here. I have a good rooms available for me to enter here. Because I know I not hit the nerve here. The nerve is pushed upwards. So we can go safely over this part. Okay. So this approach will depend on where is the fragment line and where it is pushing the nerves or the dural sac. Okay. This we can make out on coronal sections. Okay. This is a axial section. That's the axial section. In the axial section, what you can see, this is the vertebral body over here. Vertebral body. You can see the pedicle over here. That's a pedicle. You can see the pedicle here. Right?
Yeah.
So that's a pedicle here. There's a transfer process. Okay. This is the superior arterial process over here. Okay, that's a lamina over here. This is a spinous process. And now you can see here inside, this is spinal canal. And in the spinal canal, if you can see here, can you make out something here? That's a dural sac. That's a dural sac. And inside the dural sac, you can see these small dots over here.
Mm.
These are the roots which are inside the thecal sac. And if you look at closely over here, just inside the pedicle over here, there's another dots over here. These are the exiting roots. Because these exiting roots, when they approach their foramen, they go just medial to the pedicle, and then they come out of the foramen. Which means when they go towards the foramen, they go out of the dural sac. They fit themselves into the pedicular notch over here, and then they come out of the foramen like this. Understood? Now this section is taken from where? This section is taken from here. That means this section is taken from this part. How can you say that this section is taken from this part? And why not this part?
Because we can see the pedicle in the MRI.
Very good. Because in the axial section, we can see the vertebral body here, and we can see the pedicle on both the sides. So that's why we can say that this section is taken from this part of the vertebral body. Okay. Now, if you look at this blue line, now still where are we now? We are in this part, because we can still see
the pedicle.
we can still see the lowest end of the pedicle over here. And look at this, what is here? Now you can see very clearly the roots. What are these? These are exiting roots. Exiting roots. Now if you go more down, now if you look at this, now this section is taken from here. Now you can see here, the pedicle is off now.
Yeah.
Which means the section is taken from this part.
Foramen.
The section is taken from this part. Because why we are saying this? Because we can see the bone here, but as you go posteriorly, we can see the foramen here with the nerve root. Nerve root is coming out from here with the nerve root here. Okay, and posteriorly we have the facets over here. Understood?
Yes.
Now we go. Now you can see this root is going out of the foramen. Root is going out of the foramen, but we are still in the vertebral body. That means we are somewhere in the lower part of the vertebral body over here. As you go down further, now look at this. You see the change in the color?
Yeah.
Which means now this section is taken from the end plates. And what has happened to the nerve root? It has already exited the foramen. It has already exited the foramen now. Okay. And this section is taken from the end plates. We go further down.
Disc.
And now you can see this section is taken from the disc level. From the center of the disc, this is the area where we can see clearly the facet joints. Now you can see the facet joints over here. Can you see the facet joints here? Okay. And you can see the disc, and you can see over here, this is the annulus, and that's the nucleus pulposus here. All right. And where is the exiting root now? The exiting root is already out of the foramen now. Right? It's already out of the foramen. And look at this traversing root. Earlier it was, everything was here. Now the traversing root is now going towards the periphery. It's not ready to go out of the thecal sac. At the disc level, it is still within the thecal sac, the traversing root. Exiting root is out. Okay. Now this section is taken from where? From the lower part of the foramen. And now we are reached to this level now. This level. Where we can see now the pedicle of the lower vertebra. And look at this, what is happening to this traversing root now. Now the traversing root has become exiting root for this disc. Okay. Now it is coming out of the thecal sac and is going to fit just under the medial to the pedicle. Okay. Understood?
Yes.
One important structure here is the, what is this?
This is the ligament flavum.
That's a ligament flavum. Yes. That's a ligament flavum. And what is this?
Epidural pad,
That's
epidural
epidural
space.
space. That's epidural space. Okay. And this is a thecal sac with all the nerve roots inside. Okay. So what is the importance of this? These sections. So these sections will tell you the type of the herniation and which nerve root is getting compressed. Okay. Whether it is a central herniation, suppose if you take the section from the this level, whether it is a central herniation, whether it is a paracentral herniation, which usually compresses the which nerve root? The traversing root. Or it is a foraminal herniation, which may be compressing the exiting root. Or it's a extraforaminal herniation. Again, it will compress the exiting root. Okay. So when this is called the Cambian's triangle between the exiting root and the traversing root. So when we do endoscopic discectomy, this is the portion from where we enter inside. So most of the time, like most of the cases I do is like a this thing outside in techniques where I enter into the canal directly. In some cases, when we do core decompression, in that case, we go enter like this inside. So you can see this. It is very important for us to understand where is the nerve root line. Okay. So before performing this endoscopic discectomy, we have to see these sections. Okay, whether we have a space or not. Okay. Understood now? Why it is important to see all these sections? Now this is a striatal section. Now we are taking the sections like this, from left to right or right to left. Okay. Now since look at this. This section is taken from here, which means it is taken from outside the foramen. Just outside the foramen, we are taking this section. As we go medially, now we are just taking this section from the to the foramen. Now look at the foramen here. Can you make out this foramen here completely?
Yes.
You can see the nerve roots over here. So these are the exiting roots. These are the exiting roots, right? Suppose there is a foramen herniation. Now, why this is important? Why these sections are important to see? If you see that there is a foramen herniation, in that case, what will happen? You will see the herniation over here in this section. And what you will see is that where is the new root? How much it is getting compressed, whether it is compressed or not. Suppose there is a herniation over here, and you see this fat around the root, which is clearly visible. That means herniation is there, but it is not sufficient to compress the nerve. But if there is herniation over here, and nerve is pushed upwards, and there is no fat around here, that means this foramen herniation is compressing the exiting root. Understood?
So can you please come again?
So suppose if we see this section from the, if we take a section, let's say this one. When we take a section from the foramen, sagittal section to the foramen, that time we'll see the disc over here. We'll see the entire foramen. We can see the septal fat over here. Okay, and we can see the nerve root over here. And we can see the fat over here. Some space between the pedicle and the nerve root, which means it is a free nerve root over here. Now suppose there's a herniation over here. Let's say in this case, suppose there's a herniation over here. And if you still see the root over here with surrounding space over here, which will tell us that although the herniation is there, which is into the foramen, but it is not sufficient to compress the nerve root. Nerve root is free. Okay. But if the herniation is there and it is pushing the nerve upwards and there is hardly any space over between the pedicle and the nerve root, that means this herniation is sufficient to cause the compression of the exiting root. Okay. So when we do transforaminal, you have to see this section, because a lot of times the herniations are not typical central, typically paracentral, typically foraminal. They are most of the time they're combination of that. Maybe central herniation extending up to the paracentral area, or paracentral herniation extending to the foraminal area. Now suppose there is a paracentral herniation and you want to target a traversing root. So in that case, and this paracentral herniation is also extending into the foramen. Okay. So in that case, if you want to target this nerve, what will happen? There is hardly any space. In that section, you can see that there is hardly any space. If you want to target this nerve, okay, there is hardly any space over here. So what will happen? Your target for the transforaminal is this area, right?
Yeah.
So if there is no space here, if the herniation is there, it is compressing the nerve upwards. There is no space here. If you try to approach this, approach this foramen, you will hit the nerve root. In this case, what will do? You want to target the exiting root. In this case, you will not go from here. There's one which is called infraforaminal approach. That means you can go from here. But if that is not possible, because if the herniation is covering the foramen, what will happen? If you target this part, you will enter the disc. If you try to enter here, you will hit the nerve root. Okay. In that case, what you'll do? You will go one level above. You'll target this nerve root from above. One level above. Okay. Understood?
Yes.
Now, as you go more medial, now we are approaching towards the lateral recess. Now we can see the traversing roots. Now you know the meaning of the exiting root and traversing root. I think we discussed in the anatomy section. You know? Now what is this? Why we call it traversing root? Because it is traversing the disc. So exiting root, traversing roots are in relation to the disc. In the foramen, this is exiting route. Now, as we go towards medially, this exiting route will come out of the foramen, and what we see is the traversing route. Okay, because you can see here, the traversing routes are they're coming out of the dural sac.
So you're talking with respect to the lower disc?
To this disc. If you
Okay,
talk about this disc, let's say this is your L3, L4.
okay.
So which nerve root is this?
So it will be the
Huh?
L2,
Traversing route.
L3.
L3.
No, this is L4. L3 is already here.
L3.
L3 is already exiting now.
Yeah.
Remember, when we take sections like this, axial sections, we saw that over here, exiting route is already into the foramen now.
Yeah.
So for L3, L4, L3 is the exiting route, right?
Yes.
So L3 is already exiting the foramen. Now we are going towards the paracentral area. As we go towards the paracentral area, now exiting route is here. What we are seeing is the traversing route now. So this is your L4.
Yeah.
Here. Am I clear on this?
Yes. Sir.
Okay. Let me make another one diagram here. I'll explain you with this. So this is a pedicle over here. So initially all the nerve roots are in the center. Okay, in the thecal sac. As
Yes.
this nerve goes towards the disc, okay, it will enter into this groove here. Okay, and it will go like this. Okay, the other root is here, and we start approaching. Okay, now let's say this is your L3, this is your L4. All right.
Yes.
So which root is this?
L3. L3.
L3, and this is your
L4.
this 4, this is your 3, right? So why we call it as exiting and traversing? Because exiting means in relation to the disc. So before reaching the disc, it is already exiting. That's why we call it as exiting route. And why we call it as traversing? Because it is traversing, it is passing the disc. That's why we call it as a traversing route. Understood now?
Yes.
So when you
Yes.
take a section from here, if you take a section from the foramen, which nerve you are seeing here in the upper part?
Entry.
Hmm?
The exiting nerve should be entering.
We saw in the pedicle section, when you take a section from here, we saw that there's a pedicle, and just below the pedicle there's a root, and there's some space between the pedicle and the root, which is epidural space, right? Supranuclear space, where we target our transforaminal.
Yeah.
Okay. And when we take a section from here, then now which root is coming here?
That will be the traversing
Yes.
L4.
Traversing L4.
That's a traversing route. Yes. You can see the traversing route. Now this traversing route is going here. This route is going here. Understood now?
Yes.
Yes.
Now what will happen to these routes? There are other routes also which are traversing, right? Where are they? These all are inside the thecal sac. Okay. So there's a thecal sac which is covering these routes. Okay. The thecal sac is covering these routes. Understood? Now, when they go towards the respective foramen, they come out of the thecal sac. When they go towards the respective foramen, they come out of the thecal sac. Okay? Understood?
Yes, sir.
Yes.
So what will happen when we take a section from the center, from here?
Lot of root.
Now, as you go more medially, when you take a center section from the center, now you can see all the roots over here as a bunch. Now, suppose there is a central herniation, you will see the herniation over here. If it is paracentral herniation, you will see the herniation over here compressing the
Which will be the traversing nerve route.
Exiting or the traversing route.
no, the traversing route.
Yeah.
Traversing nerve route.
Okay. If it is central herniation, it will may compress all the roots which are traversing. If it is purely central herniation, your exiting route is free, traversing route is free, but all the bunches of the nerves which are traversing from the center, they may get compressed. Okay. All right.
Yes.
Now, as you go towards the left side, now you can start seeing again, you can see all the separate routes.
Traversing nerve.
This traversing routes. Now we go towards the foramen. Now again, you can see the exiting routes. Right?
Yes.
This is on the other side. Understood?
Yeah.
This is how the nerve roots lie within the thecal sac. As they approach this pedicle, as they approach their respective foramen, they start coming out of their thecal sac. You can see here. They're coming out of the thecal sac. They are going into the foramen and they are exiting to the foramen. Where is the disc here? Disc is somewhere here. All right. And this is the DRG. You can see this dorsal root ganglions. These are the dorsal root ganglion. Okay.
Okay.
The accession to this rule is for the S1 root. S1 root comes out before the disc. Okay. See this. Now it is coming out of the thecal sac above L5S1 disc. Okay. This is the thecal sac. This is the S1 root. And this is the L5 root. So when we perform anything on the L5S1 region, we have to take care of the exiting route, we have to take care of the traversing route, and we have to take care of the thecal sac. Okay. transition vertebrae. This Dr. Sojana is going to take a lecture on this on the transition vertebrae. She is going to present a beautiful. No, not Dr. Sojana. Shelly is doing that. Shelly, you are there.
Yes, sir. Dr. Shali is doing.
Huh? Shelly is doing this transition. Huh? Yeah. So this will cover because this is very important aspect we must know about the transition vertebrae. Very frequently, you will see these kind of transitions happening in the lower lumbar region, lumbosacral transitions, but there's something also called a thoracolumbar transition. Okay, which is not that frequent, but since Saujanya has joined, we are seeing a lot of thoracolumbar transitions. Okay, now once we have understood the sections, the sequences, now you tell me what is this. First, tell me what section is this.
Sagittal. Sagittal.
Very good. Now, what sequence is this? Is this T1 or T2?
It's T2. It's white CSF.
Okay. Anyone else wants to contribute?
Both T1 and T2. First T1 and second T2. Column, first column.
Good. So this part is having T1 and this part is T2.
T2, yes.
Okay. So many times we'll see them together because
Yes,
if you want to compare, this is what we have understood. We want to compare between T1 and T2 to see the different pathologies, right? This is what we discussed. So that's why they gave it in one film, T1 and T2 both. You may have separate films for that, separate films for T1 and separate for T2. But you must always compare with both. Okay. So I'll just close this one. I'll zoom this one so that you can understand the pathology over here. Okay. Can you see this? Can you see the screen? Can you see the screen?
Yes.
yes, yes.
So as we discussed that sagittal sections, they start from the right side to the left side. Okay. So this section is taken from where? Is it from the foramen, outside the foramen, parietal, central?
This is outside the forum.
Outside.
This is just outside the foramen.
Yeah.
As we go,
This is like the forum.
you can see this is through the foramen, right?
Foramen.
In the foramen, you can see here. Can you see here the disc over here?
Yes.
Okay. The disc are looking okay here up to this level. Now, if you go towards the foramen, you can see there's a small herniation over here.
Regenerated.
There's a foramen herniation
Yeah.
at L4, L5 level. We don't know whether it's L4, L5 or L5S1. We don't know. We cannot make out on this section. We have to see the counting. Okay. But let's assume that it is L4, L5. So there's L4, L5 herniation. But what we want to see is whether it is permanent or something else. When we go more medial, towards the paracentral area, you can see this. Look at this. Look at this. Okay. There's a minor herniation here, but this one is compressing the traversing root. Can you see that root is compressed over here?
Yeah.
You look at this root, this is free. But this root is getting compressed over here. And we go more medially, central part. You go towards the central part, and you can see there's a, in the central part, there's a big extrusion over here.
Yeah.
So this herniation is starting from the central, going towards the paracentral, and extending up to the foramen area. But in the foramen area, the nerve root is almost free here. Okay. But here it is compressing the traversing root.
Yeah.
And it is also compressing the other nerve roots. Okay. So this is how we see. Now we go towards the right side. The right side is again free. Okay. All right. Sorry, left side. Started from the right side.
Left side.
Okay. And if you compare with this one, you can see this very well headed disc over here. And this is T1 and this is T2. The same we can see. Now look at this. This is what? What section is this?
Axial.
Axial section.
What
Also
sequence?
second.
What sequence? What
T2.
sequence? T2. Perfect.
T2.
Because we can see the nerve roots and we can see the CSF here. That is a T2. Now look at this number 1, 2, 3, 4. They are taken from the L5S1 region. Okay, this is 1, 2, 3, 4 here. Now if you go up over here, now this section, the 5 number is taken from the vertebral body of L5. Okay, and if you go here, you can start seeing this is 1, 2, 3, this is 4, this is 5. This 5 is taken from here. The 5 number is here. The 6 number 6, is taken from the end plates.
Okay.
Okay, and now you can see there's a herniation over here. Okay, because this section is taken from the end plate. This is slightly migrated downwards. Okay, and now the 6 and 7 number is taken from the center of the disc. Okay. Now, what is the difference here? Now, if you look at this section, which is taken from the disc, it looks like that this is a contained disc herniation, right? Contained disc herniation. So if you look only at the section which is taken from the disc level, it will give us different image. But when you see the other sections, you can make out that it is not just a contained herniation, there is an extruded portion over here. So why it is important? Suppose if you want to decompress the disc, if you look at this section, what will you say? That let me go inside, I would like to decompress it from here. Because this is a contained herniation, let's go inside and do something here. But what will happen? The fragment will remain there.
Extruded is remaining there.
Okay. So now, but because of these sections, we can make out that this is not just a contained herniation. There's an extruded material which has migrated downwards, which is lying at the vertebral body level, L5 vertebral body level. So we have to target the fragment which is lying over here. Understood now?
Yes, sir.
And what we saw in the serratus section, that herniation was in the center and which was extending into the foramen like this. See this, center, paracentral, extending into the foramen. In the foramen, it is not compressing the root, but here it is compressing the traversing over here. Okay, and we saw in the center that it is compressing all other roots also. Why we can say that this is compressing the root, thecal sac? Because the thecal sac, otherwise it will look like this. The thecal sac will look like this. This with all the free nerves inside. But here there is a crowding of the nerves. You hardly see any CSF there. Understood? There
Yes.
is a concavity which is maintained in the vertebral body and also in the disc. Concavity. Okay. This concavity is not a feature of L5S1 disc. So if you see such kind of disc at L5S1, that is not a herniated disc. This is a normal feature of the L5S1. Whereas all other discs are concave. Look at this. Look at this. Okay. All other discs are concave. Here now. And this is a coronal section now.
Hello.
You can see here. That's a student material over here. Okay. Okay. What section is this?
What is the coronal section?
Coronal section.
Sagittal.
And this is?
Sagittal.
Sagittal.
What sequence is this?
T2.
T2. Very good.
T2 disc is white.
PSF is there and T2 is there. You can see this hydrated disc over here.
Yes, white disc.
Very well hydrated disc. What is happening over here?
Disc is becoming
Degeneration.
black.
Black. Because of the degeneration.
Degeneration.
Okay. Look at here. Can you see something here?
It's getting herniated.
Herniation.
Herniation.
Hydrated, but what is that? This is a big tear on the disc, annulus.
Yeah.
There's a big tear in the annulus through which nucleus vertebrae started coming out.
Yeah.
And it is still contained. Outer annulus is still intact. Okay. Why it is important to know? Because in such cases, we can do something inside the disc to decompress the disc. Okay, because it's a contained disc herniation. We can go inside the disc and we can decompress it from here. Maybe we can use ozonoclasis because there's a hydration is also there. Hydration is still maintained over here. Here the hydration is lost. Okay, but hydration is still maintained, so we can go for the ozonoclasis in this case. So depending on the MRI findings, we can select our interventions where we have to target. Okay. If you see, look at this one. Can you see some white dot over here?
Annular tear.
That's a tear. This is called the high intensity zone, HIZ head. Okay. Now look at this. This section. Can you see something here? Some whiteness over here.
Yeah.
So that's a facetal fluid. Because this section is not taken from the foramen level where we have facet joints. So here we can see the facetal fluid. Okay. So suppose there's a cyst inside. In that case, what will happen? We'll be able to appreciate the facetal, and there's a cyst going through the facet. It is going like this. Okay. That's what. Same thing, same facetal cyst. If you look at this section, coronal section, can you see the facetal cyst over here? Correction over here, both the sides. This is a section. This is the fluid collection inside the facet joints. And you can see this clearly. This high intensity zone over here.
Yeah.
Okay. So there's so many things which you can see on the MRI. So what sequences is you said about us T2 and other, what else? What else is there? It's a fat suppress. You can see the fat suppress, right? You can't see the pupillary fat. You can't see this. This is suppressed. Fat is suppressed over here. Look at the bones. They become dark. Okay. Understood?
Yeah.
Yes.
So that is the importance of seeing all the sections, sagittal sections, coronal sections, and axial sections. Where's the fragment lying? Which root is getting compressed? From where the cyst is coming? Okay. So we'll see the herniations. The herniations, as we discussed, maybe central herniation, parasternal herniation, coronal herniation, or extrafemoral herniation, or you may have combination of both, combination of all the three, or combination of these two, or combination of these two. Okay. Most of the times, it's always a combination. Okay. And depending on that, we can see on the MRI whether it is our traversing root is compressed or it is exiting root is compressed. So whether it is central herniation, we can see the exiting root is now. When again I said that we are talking exiting traversing in terms of the disc. Okay. So let's say if it is
Yep.
let's say if it is your let's say this is your L3, this is your L4. So which root is this?
L3.
Good. This is your L3 and this is your L4.
L4.
Okay. Now suppose the herniation is here. What type of herniation is this? What type of herniation is this? Paracentral herniation,
Paracentral.
Paracentral.
right? Paracentral herniation is compressing which root? Traversing or exiting?
Traversing.
Exiting.
It's the L2 disc, so it's traversing.
Very good. Excellent. Because now we are talking in terms of this disc. We are not talking about this disc. Now we are talking about the
L2, L3.
L2, L3 disc. Okay. This is exiting. This one is exiting for L3, L4 disc. Right? For L3, L4, this is exiting. But for L2, L3, L3 is a traversing route. Okay. Now if we talk about this herniation, it's a purely central herniation. Purely central herniation will spare the exiting route also, will spare the traversing route also. It will compress the thecal sac with all the nerve roots inside. Understood? Okay. So this is, what type of herniation is this?
Is it
Paracentral.
foraminal?
That's a foramen herniation, yes. So which root is getting compressed here?
Is the L4 exiting?
L4 exiting route, yes. Because now we are talking about the L4, L5 disc. Okay, so L4 is getting compressed over here to the foramen. And since this foramen, this herniation is migrated slightly upwards, it is pushing the nerve upwards. Look at the space here. But here, there is no space. Okay, now everything is clear now. The concept of everything is clear now. Okay, good.
रिया चलने दो ना प्लीज.
So this is how we take the sections, and this is how we can see the sections taken from here. Axial sections taken from here, We can see all the nerve roots. We can see the thecal sac. That's the thecal sac. We can see the thecal sac. See all the nerve roots inside. We can see all the nerve roots inside. And what we are seeing here is the exiting root is already out. So exiting root is already out of. Okay.
Please.
So when we take a section from the lower end over here, lower part over here, okay, this part, so this section is taken from this part, right? Why we are saying this taken from this part? Because we can see the bone now here, okay?
Yeah.
And we can see this pedicle is just starting over here. Pedicle is just starting over here, okay? And now the traversing root is going out of the, this is a traversing root, right? That's a traversing root. Now this traversing root is going out of the thecal sac. You can see this is going out of the thecal sac now. Okay. So if there's a herniation over here, parietal herniation over here, and it is migrated downwards, you will see the herniation over here and it compressing the traversing root over here. Okay. Now this section is taken from the pedicle here. Okay.
Yeah.
Now this again from here, this part. So now you can see this is the exiting root over here. Okay. So this is exiting out of the foramen. So this come out of the foramen, exiting. Okay. So these sections are again very important because at times we have a, now look at this. This section from where it is taken? It is taken somewhere from the upper end plate. Okay. It is taken from the, no, we don't know L5S1, we don't know that. But we know that it is taken from the upper end plate. Because what we see here is that exiting root is out and we can see the thecal sac over here. Okay. This section is taken somewhere from here. Okay. Now if you go down, now we can start seeing the disc. Okay. From here, it looks like that there's no herniation. It's just flattening is there. You can see the thecal sac with all the nerve roots. Okay. This section is taken from the upper part of the disc. There's no herniation. Now as you go down, we can start seeing this. Look at this. What is happening here?
There.
There's a tear over here. So in the lower part of the disc, there's a tear over here. Now as you go further down, now you can see there's a extrusion over there. Okay. All right. Now you can see here, there's a herniation over here. The fragment is lying in the lower part of the disc. Okay. At the level of lower vertebral body. At this level. Okay. This is a fragment which is lying over here. Contained herniation, extruded herniation, and sequestration. Contained herniation means the outer annulus is intact. Simple. Okay. There's other methods on MRI. How to see that? We have to see the base and the length of the herniation. If the base is bigger, then you call it the contained herniation. Okay. If the base is small, when the disc vertical comes out, the annulus has a property to retract. Okay. As long as it is protruding, it will take along with this the annulus. So that's why the base is bigger. When it comes out, annulus will retract and it will close this. And now you can see this portion is small and this is bigger. This is called extrusion. Contained herniation, extrusion. Sequestration means when this material, nucleus material, has come out of the disc and it is not in continuity with the parent disc. Then we call it as a sequestration. So there are various terminologies which we use for the disc pathologies. So we must know these terminologies very well. Okay, because all of them have a lot of importance. If it is content herniation, our treatment modality will change. If it is extrusion, treatment modality will change. If it is sequestration, our target will change. Okay, so these terminologies are really very important. So Dr. Sojana is going to take a lecture on this terminologies also, these pathologies and the terminologies. What terminology we should use. So look at this, some of the examples. I'll show you some of the examples. You can see here. This is what kind of herniation is this?
Foramen.
That's a foramen herniation. So when we take a section in the axial section, we can see the foramen herniation. But what we cannot make out from here, you can see the exiting root here, you can see the exiting root here. Can we make out whether it is compressing the exiting root or not with this section?
No.
It's difficult to see that, right? It's not possible to see that. We can see the exiting root, we can see the exiting, both the roots are free here as per the axial sections. But when you take a section, but suppose if you take a section from, let's say if you take a section from here, let's say we take a section from this part. Which section is this? Sagittal or coronal? Sagittal, yes. So when you take a section from the sagittal section, when you take a sagittal section from the through the foramen, what we are seeing here is that there's a big herniation over here, and it is compressing the nerve root area. Okay, understood? Look at this. Nerve root is completely free. You can see the epidural fat over here. But here, this is protruded over here into the foramen, and it is also pushing the nerve pods, and there is hardly any space between the pedicle and the nerve root. That means it is compressing the exiting root. Okay, so that's why it is important to see the multiple sections. Look at this. From axial sections, you can see the root here, traversing root. On the right side, it's free. Left side, where is the root? The root is here. It is pushing the root over here. It's pushing the dural sac over here and pushing the root over posteriorly. Okay. From here, from the axial section, it looks like it's a central paracentral herniation. But when you take a section from the foramen, that time we see that this extrusion is not only limited to central paracentral area, it is also extending into the
Foramen.
foramen, and it is compressing the traversing root. And the exiting root over there, L5. Okay. So this is the sequestration of the disc. Sequestrated disc. Now, if you are in the habit of seeing the sections taken from the disc, suppose if you take a section, if you just see the section taken from the disc, what it looks like. See, the thecal sac is free. It's like a protruded.
Contain disc herniation.
Nothing, it's not compressing any root. Thecal sac is free, right? But when you take a section from here, then we see the big extruded sequestrated material lying over here and compressing the entire thecal sac, pushing the thecal sac, and also slightly compressing the traversing root. Okay. Here's again a sequestrated material over here. Big sequestration over here. Look at this. So it is not only limited to this part, it has gone down and it's compressing the other root which is down below, S1 root over here. Now in this case, there is a extrusion. What is important here is this extrusion over here. Now if you look at this, compare with this T1 image. Can you see something here? What is this?
Epidural fat.
Epidural fat. Where is this? Anterior, posterior?
Posterior.
Posterior.
So what is happening here?
The epidural space is getting compressed.
Yes. So this extruded material is such a big extrusion that it has gone to the posterior epidural space. Okay. So suppose if I want to do if you want to remove this material from here, if you want to do discectomy in this case, let's say transfemoral endoscopic discectomy, what will happen? You will be able to remove this, but you cannot reach here. So in this case, you have to go for the interlaminar approach. Because through the interlaminar, you will enter the epidural space, posterior epidural space, and you can remove it from there. Okay.
It's 22 hours.
So this you can see here, superior migrated disc. Superior migrated disc, right? This is
Down migrated.
down migrated. At the body, at the level of the vertebral body, there's a big piece over here. Foraminal. Look at this. Foraminal extrusion. Such a big extrusion in the foramen. Right? It's totally compressing the nerve root over here. What is this? What section is this?
Sagittal section.
What
Yeah.
sequence? What sequence? Left and right?
T2.
Both are?
sagittal.
Left,
Both
left
are-
is T2, right is
Left is
Left side is stir image. Fat is suppressed.
no, first tell me the section. Oh, sorry, sequence T1 or T2?
T2, sir.
T2.
T2.
Both are
left
T2.
side T2.
Yes.
Both
Both are
are T2.
perfect. Both are T2. Because we have CSF there. Right?
T2.
Yes, T2. So both are T2. Now look at the disc. Yes. Can you make out some difference?
Yes, sir.
In the T2, this should be white, right?
Yeah, but
Yeah.
Stir.
Huh? So what is happening here?
sir, it is T2 only.
Yes. Good.
Yeah, but here if you see the higher disc, it is actually it is hydrated properly.
Which one?
Lower down,
This one is hydrated, but this one is
Loss of
Behind.
loss of water.
loss of water. Yes. So this is Dehydrated disc.
Dehydrated disc. Yeah.
We're not saying that this is a pathological degeneration. Why we are not saying it's a pathological degeneration? Although these are dark-looking discs, dark-looking disc means degeneration of the disc.
Mm.
Okay, but this is not a pathological degeneration. We are calling it as a physiological degeneration or physiological dehydration of the disc. And these are not painful. These are not painful. This is just a dehydration, physiological degeneration leading to dehydration of the disc. That's why they are looking dark. And why we are saying that these are not painful? Because what we have to see is that if you look at the annulus, the
End plates.
if you look at the annulus, they are intact, end plates are intact, the disc height is maintained, right? So these are the kind of the discs which are just dehydrated discs. Okay. Only thing which is going to happen in such patients is they will have the less flexibility. Okay. The flexibility is less. That's it. But these are the discs which are usually not painful because annulus is intact, end plates are intact. Okay. So every dark looking disc is not painful. Understood? What is this? T2, hydrated disc, hydrated disc.
Annular tail.
Dehydrated disc with HIZ.
Extruded disc.
No, there's no extrusion. Here's the extrusion. This is just an annular tear. You can see the outer annulus is intact over here. See the outer annulus is intact over here. There's only this dot is there, which is called a high intensity zone, HIZ. So whenever there's an annular tear, because this nucleus material is highly inflammogenic. You remember in the anatomy section, I told you about this.
Yes.
Yes.
Material is highly inflammogenic because this is a foreign body for our own body. Right? This is a foreign body. It comes from the notochord, right? It does from the notochord. It remains inside throughout the life. It doesn't come in contact with your circulation. So that's why it is a foreign body for us, for our own body. When it comes in the contact with any vessels or somewhere in the vascular area, it causes severe inflammation. And that will cause severe extrusion of what is it called? Exudation. Okay, and that will lead to the accumulation of the fluid. Okay, so that is called high intensity zone. This is a sign of annular tear. Understood? Look at this. On the MRI, you can see in the sagittal section, you can see that big annular tear. Can you make out?
Yes, sir.
Okay. So all these pathologies, we can manage these pathologies. We have different interventions for these pathologies. When we start talking about the pathologies, interventions, that time we'll discuss all these pathologies again. Okay. This is just a standing MRI. You can see that. Contrast MRI. Contrast MRI. Whenever you have any suspicion of the infection, or if you are referred a patient after any surgical intervention, or if you do some intervention, whatever intervention, described intervention, and a patient comes back to you with the severe pain or severe stiffness or increase in the pain, you must always go for the contrast MRI. Don't just order MRI LS spine. Order contrast MRI. Because what we want to rule out now, infective cause, or maybe some disc fragment which is lying there. Okay, maybe some hematoma over there. Okay, so what you have to do is we have to always order the contrast MRI. Okay, so contrast MRI will show us the inflammatory areas. If there's some correction, it will come out. Okay, also, if you look at this side is free, nerve is free, but there's some material over here. Okay, on T1, T2, it will look dark on T1, T2. We cannot make out whether it is a extruded material which is lying there or it is something else. But when you go for the contrast MRI, then you can see this contrast is taking up over here. That means there's some inflammatory process going on over here inside the disc. And also, if you look at this, now there's an enhancement which is happening over here around the nerve. That means it's a fibrovascular growth which is developed over here, which is common after the surgical interventions. At times, this fibrovascular growth becomes so intense that it will entrap the nerve. So that is why even after surgery, patient may come to you with the radicular pains. This we see a lot of times even with the endoscopic procedures also. When we do endoscopic hysterectomy, that time when we handle this area, there may be some fibrovascular growth develops over here because we are working over here. And the patient may develop some fibrovascular growth around the nerve roots, and the patient will come back to you with the radicular pain. Okay, especially after surgical intervention or after some discal procedure, if the pain has increased, if the stiffness has increased, don't just take up the case without getting a fresh MRI. Okay, even if the patient is referred to you by somebody that we have operated this patient, now the patient has radicular pain, give transforaminal, give epidural. Don't do that. Rule out infection first, then only take up the case. Look at this. This is T2 image. It looks like a healed vertebral body. Okay, healed. But if you go for the contrast, you can see there's a lot of activities going on inside. Okay. So this is what I was talking about, the body changes, type 1, type 2, type 3. Why it is important to differentiate them? Because the treatment modality will change depending on the type of the body changes. So if you have these kind of changes, type 1 means dark on T1, white on T2, which is water. Water means it's edema. That means it's an inflammation. If it is inflammatory, our target is anti-inflammatory. Okay, maybe oral medication, oral steroids, or discal steroids, or interdiscal ozone. They act as a anti-inflammatory agents. If you have this kind of changes, type 2, that is fatty replacement. These are the patients who will have discogenic, sorry, not the vertebrogenic kind of pain or the discogenic kind of pain. They will have discogenic or the vertebrogenic kind of pain. So if they have discogenic kind of pain, in that case, we have to go for the disc denervation. We have to ablate the nerves which are grown inside. We can do with the radiofrequency RF, mycoplasty. There is no role of mycoplasty in such case. But if you have this kind of changes, you can go for the mycoplasty. In this case, we want to target the what? We want to ablate the nerves. We want to denervate the disc. Because this is already denervated disc. We're not going to repair this disc. We have to denervate it. It's a denervated disc. But if you have a condition like this, now if you look at this out of 3, this is the most horrible looking desiccated disc. And look at this end plates. This is dark on both. That means it's a sclerosis. It's a sclerotic, desiccated disc. Now these are the discs which are not painful. Why they are not painful? Because disc is totally dry. The end plates are sclerosed. There are no nerve endings over there. Though they will look most horrible out of these 3. But these kind of discs are not painful. If there is a pain in this area, the most common reason is either the facet involvement or the myofascial component is there. So we have to target either facet or the myofascial pain. You look at this, there's a vertebral body, there's some hypointensity inside, darkness inside. This is T2 image. We can see some edema over here. Along with that, we can see some erosions of the vertebral body over here. Erosions. So in such case, if you go for the contrast enhancement, you can see there's an enhancement happening over here. That means there's some active infection which is going on inside. Lumbar canal stenosis. There are different grades of the lumbar canal stenosis. Okay. There's a scoring system for that. You can just read the scoring system. Now look at this. Here, there's no stenosis. You can see the thecal sac. You can see all the free nerve roots. You can see here some clumping was happening over here. Rootlets are getting clumped over here. Okay. Here you can see this is totally obliterated. There is no space between the roots, but the epidermal space is still maintained over here. Okay. Here the epidermal space is still maintained. Okay. So if you have a patient who comes to you with this kind of condition, with there's hardly any compression showing, but epidermal space is maintained, maybe you can go for the disc core decompression over here. You can create some space over here inside. This is what we did today. We had similar case. So we just went inside. So normally I don't go inside, but at this time I went inside and I just cleared all this area just to create some space for the roots. And look at this. This is completely critical stenosis. There's hardly any epidermal space also. There's no epidermal space. So these are the kind of stenosis which requires surgical decompressions. Because it is not a disc which is compressing. It is a facetal joints. It is a ligament of flavum. From posteriorly, they are compressing the entire thecal sac. Now look at this. You name any pathology, it is there. You have compression, you have degeneration, you have herniations, you have facetal involvements, total degenerated disc, osteoporotic spine, everything is there. But if I say that this patient is not having any pain, he doesn't have any pain at all in this region. So that is also possible. You see every kind of pathology here. But all the pathologies may not be painful. Okay. So this is actually patient. This patient actually came with the dorsal spine fracture. So we did vertebroplasty on him, but his lower spine was having all these pathologies. But he said, I never had any back pain, lower back pain. But look at the pathologies. Okay. Now look at this. There's a stenosis over here. Stenosis over here. And if you look at this disc, so it is this which is compressing the nerve? No. Disc is very small. The main pathology is coming from the posterior ligament of flavum. There's a flavum which is compressing the nerve roots. So if you have some such compression over there, don't go for the discectomy. There's no point of going for discectomy in this case. You have to target the flavum. You have to remove the flavum from here. Okay. So disc is not the culprit always. Look at this. There's hardly any disc herniation here. What is coming from here?
Ligament of flavum.
Yes, that is pushing. That is pushing the epidermal space over here. And that is the compression over here. Facet joints. How they look on MRI. The facet joints are best seen when the sections are taken from the center of the disc. Okay. Now look at this. Compare with this. There's a facetal hypertrophy. There may be some big osteophyte over here. But luckily it is on the outer part. It is not compressing the exiting root. It is not compressing the thecal sac. Nothing is there. If the patient has facetal hypertrophy is there, facetal pain is there, we can target the facet joints only. Look at this MRI. Again, this is actual patient. Look at this. What is there?
Certain
Synovial.
system.
Yes, no, synovial cyst. It's a yes, synovial cyst. Yes, right.
Fluid.
It's a fluid. Synovial cyst. Yes, synovial fluid inside the joint. It's not forming just cyst, but it's a synovitis of the facet joint. Right? Compare with the other side. What is there? Can you see the facet joint here?
Yeah.
Can't see, no?
Let's stop it.
Because of the severe degeneration of the joint. So the same patient, same level, on one side we have inflammation, on one side we have a degeneration. So what is the treatment for this? For this, we'll go
Aspiration.
aspiration and intra-articular deposteroids. But here we'll go for the
Medium branch block.
yes, we'll go for the
Medial branch block.
not block.
RF.
Yes, we'll go for the facet denervation. Okay. So we should be very careful in selecting our terms also. We should not use this injection and block words. Okay. Block is only for the diagnostic block. That's it. So we must use correct terminologies. Okay. What is the correct terminology? Facet denervation or RFA median branch. These are the correct terminologies. The best is this facet denervation. What we are doing by bleeding the nerves, we are denervating, right? In the same patient, I did one on one side, on the right side, I did go for the aspiration, and on the other side, I did facet denervation. Okay, both are facet arthropathies, but this is inflammatory, this is degenerative. So your modality will change. Treatment modality will change depending on the findings. Understood? Look at this. There's a herniation over here, right?
Central one.
Central herniation. Look at the traversing route here. It's free. Look at the traversing route on the right side. Compressed. Okay. All right. So what will you do? Now look carefully here. Can you see the phlegm here? Can you see the facet joint here?
Yes.
Okay. Now look at this facet joint. What is happening here?
Synovitis.
Yes. And look at the phlegm. What is happening here? So this fluid, the synovial fluid inside the joint, we know that the inside of the facet is covered by the phlegm. So it's pushing the phlegm inside. It's pushing the phlegm inside. And this phlegm is basically compressing the nerve root here. So what will you do in this case?
Aspiration of the synovial
Yes.
fluid.
Perfect. You don't have to go for the discectomy in this case. You don't go for the discectomy. What I did, I just simply went inside, aspirated this, put a deposit inside, and patient was absolutely fine after that. Okay, because I could see that there's a phlegm which is compressing the nerve root over here. This herniation is central. Okay, understood? But on not just on the basis of this, we saw here we can see this, there's cyst over here. You can see in the sagittal section, you can see the cyst over here. This is the facet and it is pushing the phlegm inside here. In this section, you can see that clearly there's a connection over here. So better option was, in this case, just to aspirate the facet joint and to decompress the nerve from here. Okay, so all these kind of selection of the cases, selection of the interventions are only possible if you know how to read them. Otherwise, if you don't know how to read them, what will you do? Oh, there's a big herniation, go for discectomy. Simple, right? Look at this facet. This is what I showed you on both the sides. So this coronal section, axial section, we can see on that. We can see it on the parietal section also. So all the sections we can see this facet. But what we want to see is that whether it is compressing the root or not, whether it is pushing the phlegm or not. That is what we want to see. Or there is a cyst, whether it is this cyst is coming from the facet joint or not. In this case, we saw that the cyst was coming from the facet joint. But this is outside. At times, it becomes so severe that it forms a cyst inside. This again, you can see the ligament buckling over here. Because of the thinning of the space, it will start putting pressure on the facet joints, and there's a reduction of space, and this ligament will start buckling inside, and that will start compressing the nerve. So there's one technology for this kind of buckling, that is called interspinal spacers. Still not available in India, but that technology is also available, where you can go for the interspinal spacer. We just lift this interspinal space, and this joint will get straightened up. So this is important slide. The least degenerated disc quantified by an objective MRI-based parameters have the highest correlation with the patient's chronic low back pain. Whereas the most degenerated disc, as I showed you, desiccated disc, has a negative correlation with the patient's chronic low back. Okay. So this is what I was telling you. You can see this. There's a cyst formation. It is compressing the nerve. What we have to do is we just can go inside and we can do the aspiration of this. We just did one case where we demonstrated. Maybe Sojana, you can show them on the group. You can share that video. We did that.
Yes, sir.
And after that, although there was a very big cyst which was compressing, so we did a interlaminar and we
Interlaminar.
we removed that cyst from there. But at times we will be able to aspirate it from there also. But that is only possible if it is a cystic swelling. If there is a cyst over there, if there's a fluid collection. At times this cyst becomes organized. There's maybe some hematoma inside, and that gets organized. In that case, we have to go for the decompression, open, surgical. Now, these kind of organized cysts we cannot remove through the facet joints. If it is organized, if it is solidified, we have to go for the excision. What is this?
Ligamentum.
Ligamentum flavum will look white or dark.
Black.
It is black, right? What is this?
Some lipoma.
Synovial.
Synovial. Synovial is having fluid inside. So what image is this? What sequence is this?
P1.
P1.
Even
If it is a fluid, how it will look? In P1?
dark.
Dark.
Lipoma.
Right. Yes, perfect. This is lipoma. Okay, because this T1 image is epidural lipoma. Okay. This is the organized cyst over here. maybe some hemorrhagic cyst over there, and that is basically compressing the nerve roots. For these kind of, we have to go for the excision. This is perineal cyst. You can see the dura around this, and there's a nerve inside, and this is a perineal cyst. So for perineal cyst, to find out whether it is perineal cyst or facetal cyst, we have to go for the coronal sections. Now look at this, there's a cyst over here. Okay, so when you start seeing this, following this cyst, when you go with the coronal sections, we can see that now there's a connection over here. Okay, so for these kind of cysts, we have to go for the coronal sections to see where it is coming from. These are the discal cysts. So recently, we just 2 days back, we had a very interesting case of discal cyst. So it was basically, probably it was a discal cyst which got organized. On MRI, it was looking like a extruded disc material. So when we went from the interlaminar, we searched that, there was nothing. Then we opened the case to find out where is the material, and there was nothing. So it was actually maybe the hematoma which was there, which has taken the form of the cyst, and which was lying over there, and it got resolved or maybe it got punctured. So even after the open surgery, we couldn't find that. But on the MRI, it was looking like a very big disc herniation. Okay, so Jana, keep sharing all these interesting cases with them.
Yes, sir.
Sherry is also there. Sherry is not there today.
Yeah, she's gone home. So, she's not there in the.
So whenever you have these, almost every day we are seeing some interesting thing.
Yes, sir.
So keep sharing with them. No?
Sure, sir.
So MRI, just a brief of asking what was the interesting in this. You know?
Okay, sir.
So this is a discitis case. We can see there's a lot of body changes over here. Okay, this is T2, this is T1, and this is contrast enhancement. You can see there's a collection inside over here, and this is getting enhanced. So this is a case of discitis. So any patient coming after the disc procedure with increased pain and increased stiffness, we must suspect discitis, because discitis is a very bad complication. The sooner you detect it, the better it is, because otherwise it usually takes around 6 months to 1 year for it to heal. Or 6 months to 1 year, patient is going to eat your head. If the patient has a discitis, it's a very bad complication. Tuberculosis, port spine is not uncommon. We see a lot of cases of port spine. They just come to us with the back pain. We go for the MRI and we find the port spine there. Okay. Epidural abscess. There's a contrast enhancement. There's abscess over here, organized pus over here, and there's a enhancement over here. Very rarely we see epidural abscess, but yes, we must know the epidural abscess. Okay, all right. So I think spine metastasis and other things we'll cover in the later stages. This is not for. Okay, so this we'll cover later.